So this section is over fluid imbalances. This is very important to understand before moving through the rest of the module. So there's a couple of optional sure path lessons in here that if you do not understand once you go through the reading and through this PowerPoint, I recommend doing some extra module work because this is the basis of a lot of the future of the lessons that you will learn. Fluid and electrolytes, they're necessary for life and homeostasis. Our nursing role is to help prevent and treat fluid and electrolyte disturbances, and good assessment skills will help you pick up on problems early. So just a reminder that fluid, approximately 50 to 60% of a typical adult body weight is fluid. Skeletal muscle holds most of that water. I thought this was an interesting chart that shows how much percentage of body weight that is water. So as you can see, a preemie, neonate, child, but I think one of the most interesting thing is the older adult. And you'll see in this chart as well that males carry more water than females. So when you're going through the mechanisms, just review intracellular and extracellular of fluid. There is also, your intro to patho, that you should really remember those intracellular and extracellular. Know the importance of electrolytes and know the fluid movement in capillaries. Those are both important things to understand before moving forward. That leads into fluid spacing. So you've probably heard this idea of third spacing because that is what a lot of people think of as something extremely a huge issue, basically. First spacing, totally normal. We like first spacing. Second spacing is abnormal, so that's where we get edema, a little bit of swelling. And then third spacing, that is where fluid accumulates in a part of body where it is not easily exchanged in the ECF. So it is literally trapped in that area and can cause some dangerous issues. So in our previous modules, we've talked about liver issues, and with that came ascites. This is considered third spacing. So as you can see in this video, the swollen belly, and then you can see in the picture of the anatomy that you can see where that fluid is trapped and it is not being reabsorbed into the body. Tonicity. So this is important, thinking about your different kinds of solutions, hypotonic, isotonic, and hypertonic solutions. This is fluid with the same osmolarity as the cell interior. Really, in isotonic, there's no fluid movement between the two fluids and doesn't have an impact on red blood cells. As you can see with hypotonic, makes them swell, think hypo, and then hypertonic, they shrink. So hypertonic solutions, it's a solution that its concentration is greater than the absolute concentration of serum. This is where osmosis occurs. If you don't remember osmosis, take time to go back to your patho. Fluid is pulled from the cells and interstitial tissue into the blood vessels, so cells shrink down. So this could be 3% saline, 5% saline, 3 and 5% saline, or dangerous salines that you really want to be careful with. And then D5NS. Isotonic solutions. This is the same solution concentration as serum and other body fluids, so you're not causing this big fluid shift within them. Isotonic solutions stay where they're infused and in the blood vessel, and so it does not affect blood cell sizes. Does not cause fluid shift. Really, normal saline and lactated ringers are the ones that a lot of people think about, and D5W. One that's not on here that is becoming a newer thing is plasmolite. That is said to be the closest isotonic solution to blood. Problem is there's not a lot of testing on it, so more to come in the future with that. Hypotonic solutions. And I say it like that in my head every single time. Hypo, so you're thinking lots of cells swell. Has decreased solute concentration than the serum. Causes solute concentration of serum to decrease and osmosis occurs. Fluid shifts out of the blood vessels into the cell, and where interstitial spaces where solution concentration is higher. So this is your half normal saline or a quarter saline. So a reminder, hypotonic, you want to go out of the vessel. Isotonic, stay where I put it. And hypertonic, with the E, enter the vessel. I like that little quick tips when you're trying to remember. Imbalances. So you got fluid volume deficit, which is hypovolemia, and fluid volume excess, which is hypervolemia. You will notice in your study notes that it's recommended that you really compare and contrast these because they are quite different. When you're assessing fluid balance, you should really look at health history. Daily weights is a big one. We do this a lot with our people who are maybe or retaining water, such as CHF, which you'll get to in the future. But a daily weight is extremely important. They need to be in a very similar bed, or standing is usually the best, in the same clothes as possible, and you really want to get that accurate daily weight at the same time. Listening to lung sounds. You know, if you start to hear crackles in the lungs, maybe they're holding on to a little bit of fluid. Intake and output. Are they outputting a lot? Are taking in a bunch? You know, did we just give somebody 4 liters of saline boluses and they only peed 300? Things like that we need to think about. Their vital signs, their skin turgor, their mucous membranes. There's a thing with kids that they say if a kid's crying, looks like they're crying and there's no tears, that's not good because they're so dry. It's the same a lot with older adults though. You'll look in their mouth and their mouth is just extremely dry. Neuro changes can happen, especially in the elderly people. And then labs, urine specific gravity, H&H, urine sodium, albumin, serum osmolality, BUN, creatinine, and total protein all can tell us about their fluid balance. So with fluid volume deficit, there's a loss of ECF and it's greater than the intake of fluid. Water and electrolytes lost in the same proportion as found in normal body fluids. So that causes the hypovolemia. It's really dehydration. Water and electrolyte losses are equal. So you're not just losing potassium, you're not just losing something, you are literally losing water and electrolytes. Electrolytes remain the same unless other imbalances are present. And dehydration really is the loss of water alone. So you'll have increase of sodium levels. So that's really how you can tell the difference between hypovolemia and dehydration. So think of hypovolemia as did they cut themselves and bleed a lot to cause this kind of hypovolemia. And then dehydration is more of they have not had enough water intake, so their sodium levels are really high. Causes of fluid volume deficit. It could be a lack of intake. Maybe they're NPO for a great length of time. Dysphagia, internal feedings, impaired thirst mechanism, think elderly people, or diabetes. The excess fluid losses, vomiting, diarrhea, fever, I think any of our GI, you know, bugs that go around. GI suction, right? Think in your last section where you put an NG tube down. Blood loss, burns, lots of sweating, third spacing. So third spacing is hard too because you're not seeing that fluid loss. It's just hiding somewhere. You have to go find it. Fistula drainage and diuresis. Clinical manifestations of fluid volume deficit: thirst, dry mucous membranes, restlessness, drowsiness, lethargy, confusion, dizziness, possible seizures and coma to the extreme. Weight loss, postural hypotension, decreased urine output, urine specific gravity increase. Look at that lab number, remember that lab number. Increased heart rate and respiratory rate, decreased blood pressure and CVP, decreased skin turgor, delayed cap refill, sunken eyes, and flattened neck veins. Our nursing diagnosis and our goal, fluid volume deficit related to any kind of things. Client will have adequate fluid volume. How are we going to help that? We're going to try to get them back to a normal level. Management, we're going to restore fluids orally is preferred, but sometimes that's not possible. So IV. Treat underlying cause, daily weights, accurate INO, monitor closely for overload, and monitoring for worsening condition of hypovolemic shock. And then you have the opposite. You have fluid volume excess. This is hypervolemia, so abnormal retention of water and sodium. Usually serum sodium will stay normal. Causes increase of fluids, increase of sodium, compromised regulatory mechanisms. So this is your congestive heart failure that I was talking about earlier, cirrhosis, renal failure, and the SAIADH, which is type of diabetes. And sometimes it is a normal postoperative response as the body comes back. If not treated, increased pressure of the arterial end of the capillary beds cause movement of fluid into intertissue space, increased pressure in left ventricle, then left atrium, and then back up of lungs, leading to CHF and pulmonary edema. Basically, what's that saying is your heart's not pumping to get blood through, so everything is starting to back up, which backs up into the body and sometimes the lungs. Clinical manifestations: headache, confusion, lethargy, peripheral edema. Think big thing, peripheral edema. That's why you really want to look at everybody's feet and get a baseline when you're first assessing somebody. Jugular vein distension, or also known as JVD. Abnormal breath sounds. Usually you'll see shortness of breath, cough, trouble breathing, maybe trouble breathing while or through exertion, things like that. Like, hey, they're walking, all of a sudden they're really having trouble breathing. Bounding pulse, increased pulse, and respiratory rate, increased BP and CVP. Weight gain, and increased urine output, decreased urine osmolarity. So this is a good picture of pitting edema. This would be stage 4, right? You push and you can still see your fingerprint afterwards. This shows a good edema scale. Not that you should measure by millimeter, but it gives you a good idea of the indentation when you push down. Sometimes you can have non-pitting edema. So somebody's legs are swollen, but you push it and it doesn't have this kind of pitting. And then you can have +1, +2, +3, +4 is your extreme. This is a good picture of JVD or jugular vein distension. It is best seen and pretty much only seen when a person is sitting up above, I think it's like a 30-degree angle. Management: daily weights are a big things in this population, especially like CHF. We send people home and tell them to weigh themselves daily. Monitor respirations, CV, and neuro changes. Monitor edema and skin assessment. A lot of people with these severe edema, their skin breaks down easier. Strict eyes and nose. A lot of times fluid restrictions, which can be very hard on specific populations because you're saying, oh, you're thirsty, I'm sorry, your body's saying you want more fluid, but you can't have it. Diuretics, monitoring electrolytes, putting their legs up. A lot of people, I always think truck drivers that are sitting there for a long time with their legs down get large amounts of edema in their feet. So we want their legs up, but we also want to encourage movement too. And then decreased sodium intake. And this shows the different kinds of restrictions. Just a really good picture of dehydration. I'm always a big fan of these kind of resources because it's another way to look at it. And then fluid volume excess, another memory aid. So overall, important things to know with your fluid. You want to know your volume excess versus your volume deficit, and you really want to look at the different types of IV fluids and nursing considerations. So really be aware of that while you're reading.